12 years after diagnosis. End-stage renal disease begins to appear about 15 years after diagnosis. Diabetic nephropathy is characterized by persistent albuminuria, usually defined as greater than 300 milligrams per day, that is present. Blood pressure. It occurs with both type 1 and type 2 diabetes, and evidence suggests that effective treatment of diabetes delays or prevents the development of diabetic nephropathy. This slide shows the most prominent nephrotoxic agents and where they have their effect. For our purposes, the primary agents of concern are antibiotics, specifically aminoglycosides, vancomycin, and cephalosporins, iodinated radiocontrast agents, which, as stated previously, are rarely, if ever, used anymore, and non-steroidal anti-inflammatory drugs. Chemotherapeutic agents, especially cisplatin, methotrexate, and nitrosoureas, are not ones we administer, but have a significant impact on renal function. With the exception of methoxyfluorine, which is no longer used, metabolism of volatile anesthetic agents to inorganic fluoride is not a problem with regard to renal function. In patients with diabetes, hypovolemia is a risk factor for the development of renal failure. Based on that, patients with diabetes undergoing any surgical procedure associated with significant blood loss, such as aortic surgery, trauma, or liver transplantation, are at increased risk for postoperative renal dysfunction. Essentially, no intra-op interventions other than maintenance of normal volemia and avoidance of nephrotoxic agents reduce the risk. Another factor to consider, and it could easily be the subject of a question, is the management of oral hypoglycemic agents in patients with renal dysfunction. I apologize for this busy slide, but it does provide a cohesive summary. On the horizontal axis is glomerular filtration rate divided into ranges. On the vertical axis is a list of drugs or categories of drugs. For each drug, there is an area of GFR for which the drug is considered safe, indicated by the dark gray areas. Some drugs are not recommended at all below a certain GFR, as indicated by the lighter gray. As indicated by the bars with diagonal stripes, for some drugs there is a range of GFR over which they can be used with caution, but generally at a reduced dose. As indicated by bars filled with small circles, some drugs are considered absolutely contraindicated below a certain GFR. This graph can be slightly simplified by realizing that for most drugs, the point at which recommendations change is a GFR of approximately 50 milliliters per minute. Further restrictions occur at a GFR of approximately 30 milliliters per minute. These generalizations aren't precise, but they are probably close enough to be able to answer a question on the test. It is also potentially important to remember that dosing recommendations for only one drug do not change as renal function deteriorates. Diabetic peripheral neuropathy is present in 10 to 20% of patients with diabetes. It typically has an insidious onset and is worse at night. By definition, symptoms are primarily peripheral in distribution, and they are most commonly symmetrical. Diabetic neuropathy is generally attributed to disease in the vessels supplying the nerves and affects both myelinated and demyelinated fibers. The diagnosis of diabetic peripheral neuropathy should be made based on the history and physical exam, specifically assessment of vibration, pinprick, touch, and proprioception. Motor nerve conduction studies may be abnormal in a small subset of patients with large fiber neuropathies, but are not recommended for diagnosis or follow-up in the majority of patients with diabetic peripheral neuropathy. Stiff joint syndrome is also termed diabetic scleroderma, chiroarthropathy, or diabetic stiff hands syndrome. It is described as being present in up to 40 to 50% of patients with type 1 diabetes, but may also be seen in patients with type 2 diabetes. The prevalence increases with the duration of the disease. Flexion contractures of the fingers may be present. Screening for stiff joint syndrome is done by looking for the prayer sign. Normally, as shown here, subjects are able to press their palms together. Patients with stiff joint syndrome are unable to press their palms together, so a gap remains between the opposed fingers and palms. This is obviously an abnormal exam. The abnormality is described as being due to sclerosis of tendon sheaths and limited joint range of motion, in addition to the previously mentioned flexion contractures of fingers. Some improvement in joint mobility over time may be achieved with tight glycemic control. Another screening test is termed the palm print sign. Ink is applied to the hands of a patient, who is then instructed to press his or her hands onto a piece of paper on a table. In grade 1, all phalangeal areas are visible. In grade 2, you cannot see the interphalangeal areas of the 4th and 5th fingers. In grade 3, you cannot see the interphalangeal areas of the 2nd to 5th fingers, and in grade 4, only the fingertips are seen. Diabetic stiff joint syndrome is important because there is reported to be an association between that manifestation and difficult intubation. Up to one-third of patients with long-standing type 1 diabetes are reported to present some degree of difficulty on laryngoscopy. This is generally attributed to limited mobility, most commonly of small joints, due to deposition of glycosylated collagen in the joints. There is reported to be an association between difficult intubation and a positive prayer sign. Other factors predisposing to difficult intubation include limited atlanto-occipital joint mobility and something called scleroderma of diabetes, which constitutes woody, non-pitting edema of the posterior neck and upper back. In a single study of 60 patients with diabetes, the palm print sign was described as being 77% sensitive and 89% specific in predicting difficult intubation. None of the other tests evaluated, including the prayer sign, modified Mallampati exam, or measurement of thyroid mental distance, or assessment of neck extension, was as effective in predicting difficult intubation. This concludes part 2 of my podcast on diabetes. Good luck on the exams. This is part 1 of my videocast to address keywords and phrases relating to diabetes. The keywords and phrases have been extracted from several years of in-training exams. As usual for my my presentations, there will be very few slides containing solely words. Most will consist of illustrations, tables, or graphs to emphasize the points. It might be worthwhile for you to pause the presentation on some of the slides which present significant detail. These are the keywords related to diabetes that will be addressed. The phrase in red, diabetes and stiff joint syndrome, was a new item in 2017. The first keyword is the perioperative effects of insulin. I have racked my brain trying to figure out what kind of question can be written based on this keyword. The fact is that insulin acts the same way in the perioperative period as it does any other time. Here's a list of some of the more prominent actions of insulin. The next thing that occurred to me was that the question might be related to insulin resistance, which is known to occur as a consequence of increased cortisol and catecholamines associated with surgery. This slide lists some effects of insulin resistance. Note that the increase in procoagulant factors is a result of hyperinsulinemia and is not a direct effect of insulin resistance itself. Of these effects, the effect on nitric oxide is the most interesting from the perspective of anesthesia. Eventually, I decided to address the keyword from the perspective of the surgical stress response. Stress, including that imposed by surgery and anesthesia, stimulates a cascade of responses. From the perspective of glucose control, most of these result in an increase in blood glucose. The increase in catecholamines results in a decrease in the release of insulin and an increase in the secretion of glucagon, both of which will result in an increase in serum glucose. Additional factors in the stress response include an increase in the release of cortisol and growth hormone. Cortisol increases hepatic glucose production and promotes gluconeogenesis. In addition, the combined effect of the stress response is to increase free fatty acid production. Increased levels of free fatty acids inhibit glucose uptake by the cells. The combined effects result in an increase in glucose production, a decrease in insulin release, and a relative resistance to insulin. This is the next item on the keyword list. There are at least three ways to view this keyword. The most obvious is to consider the complications of diabetes, both microvascular, for example retinopathy, and macrovascular, for example peripheral vascular disease. Diabetes is the leading cause of end-stage renal disease and adult blindness. It is also the leading cause of lower extremity amputations. It has been reported that the surgical mortality rate in patients with diabetes is 5 times that of patients without diabetes. This approach seems too obvious. The second approach would be to consider the direct effects of hyperglycemia, which may be the point of the question. The third approach would be to consider the complications associated with severe, acute hyperglycemia, for example diabetic ketoacidosis. At one point in time, hyperglycemia was considered advantageous for critically ill patients. The belief was that it provided an additional substrate for energy production. Subsequent work has documented that hyperglycemia is an independent risk factor for perioperative morbidity and mortality. Hyperglycemia is associated with a decrease in nitric oxide production and release, which leads to vasoconstriction with a consequent potential for compromised blood flow. It is also associated with a decrease in complement function and neutrophil chemotaxis and phagocytosis. The end result of these changes is to increase inflammation, increase vulnerability to infection, and increase the risk of multi-organ system dysfunction. The final approach is to consider the implications of severe acute hyperglycemia. Hyperglycemic hyperosmolar non-ketonic syndrome primarily occurs in conjunction with trauma or infection in patients over age 60 with type 2 diabetes. It is the initial presentation of type 2 diabetes in some patients. Generally speaking, the problem develops over weeks during a period of stress, for example in the presence of an infection, with a persistent diuresis due to glycosuria. Although ketones are not formed due to continued secretion of insulin, a lactic acidosis may occur due to hypoperfusion. Mental obtundation or coma may occur due to hyperosmolarity. Vascular occlusion may occur due to low flow states. A good question about HHNS or DKA would be to ask about specific lab values in the two conditions. One thing not listed in this table is that serum electrolytes tend to be normal in patients with hyperglycemic hyperosmolar non-ketonic syndrome. In the presence of DKA, patients will tend to have hyponatremia and hypophosphatemia, and magnesium will have a tendency to be low. In the presence of lactic acidosis due to hypoperfusion, the values listed for pH bicarb and anion gap for HHNS may resemble those of DKA. Treatment of DKA is the next subject to be addressed. In addition to asking about the treatment of a patient with DKA, good questions would include inquiring about the etiology and assessment of DKA. From this slide, it should be evident that 1/3 of cases of DKA are due to mismanagement of the patient's insulin, and almost equal number are due to the presence of an infection. Patients with DKA generally have increased anion gap acidosis. I want to duly note that I despise the concept of the anion gap. I don't like it first because the very word gap tends to imply something abnormal. With that in mind, how can you have a normal gap? Second, I don't like it because there are two ways to calculate the value for the anion gap, with and without potassium. Finally, I don't like it because there are two different values for normal, depending on which formula is used for the calculation. Because the metabolic acids are not used in the calculation of the anion gap, ketoacidosis is a high anion gap metabolic acidosis. Just to be clear, diabetic ketoacidosis results in an increased anion gap, even if potassium is used in the calculation. Patients with DKA also commonly are hypotensive and tachycardic, with some form of spontaneous hyperventilation. Kussmaul breathing consists of tachypnea with large tidal volumes and is associated with a metabolic acidosis. Diabetic ketoacidosis is one of the most common causes of Kussmaul breathing. As noted on a previous slide, hypomagnesemia is a relatively frequent finding in patients with DKA. The etiology of hypomagnesemia in these patients includes pre-existing conditions, such as poor dietary intake or increased gastrointestinal losses secondary to autonomic neuropathy. It may also be due to increased renal losses due to the osmotic diuresis, or a shift of magnesium into the cells, like potassium, with insulin administration. A prolonged corrected QT interval, QTC, is the most common ECG manifestation of hypomagnesemia. Evaluation of the patient's cardiac status is also relevant in the presence of DKA, although this slide demonstrates the increased risk of major vascular complications in patients with type 2 diabetes. It is useful to demonstrate the increased risk of acute myocardial infarction. DKA is associated with myocardial infarction either before the onset of DKA, since acute MI is described as the precipitating event in approximately 4% of cases of DKA, or during the episode, since DKA may result in increased myocardial oxygen demand, at least in part due to the increases in catecholamine output associated with acidosis. One word about serum sodium in the presence of increased blood sugar. Hyperglycemia results in a decrease in serum sodium of 1 milliequivalent per liter for every 62 milligrams per deciliter increase in blood glucose. This occurs as fluid is drawn from the cells into the intravascular space due to the osmotic effect of glucose. Accordingly, most patients with DKA will have a low serum sodium. It's important to remember, however, that the total body sodium will be normal. Some patients with DKA may present with hypernatremia due to the loss of free water through osmotic diuresis. Another abnormality in electrolytes may be hypophosphatemia. Studies have shown no benefit from treating hypophosphatemia in patients with DKA, but if the patient has respiratory failure, it's probably worth considering because muscle weakness is the primary manifestation of hypophosphatemia. This flowchart is a reasonable approach to the management of a patient with diabetic ketoacidosis. It's described as the DKA approach, a useful mnemonic to treat diabetic ketoacidosis. We'll go through the essential elements in some detail on subsequent slides. Delaying surgery to eliminate ketoacidosis is counterproductive if the surgical condition is creating a problem. Stabilization of the patient, however, is warranted. The first step in management is to treat the dehydration. The volume deficit is generally 3 to 5 liters, but maybe as high as 10 liters. Volume expansion needs to be moderately aggressive. Most recommend replacing 1/3 of the deficit in the first 6 to 8 hours and the balance over the next 24 hours. Remember, patients with diabetes probably do not have normal ventricular function. In patients with a history of significant myocardial dysfunction, monitoring intravascular volume may be prudent. The second step is to treat the potassium deficit, which is commonly in excess of 3 milliequivalents per kilogram and may be as high as 10 milliequivalents per kilogram. Think about that. In a 70-kilogram person, you are talking 210 to as much as 700 milliequivalents of potassium. That obviously cannot be replaced quickly. Additionally, urine output should be restored before administration of potassium. This algorithm says the serum potassium must be corrected before insulin is administered. As previously noted, the potassium deficit is not something that can be corrected by potassium administration, even in a day. Instead, I would say that the hypokalemia needs to be addressed prior to administration of insulin. Once insulin therapy is initiated, the serum potassium is likely to decrease as it moves into the cells. Remember, glucose and insulin are one of the treatments for hyperkalemia. The potassium is not lost from the body. In addition, however, as the intravascular volume is expanded, more sodium is delivered to the distal tubules of the kidney, resulting in potassium loss. Obviously, that potassium is lost from the body. Treatment of the acidosis begins with the administration of insulin. Most authors recommend an initial bolus followed by a continuous infusion. During the first 2 hours, with volume resuscitation, glucose levels may fall precipitously. In general, the maximum rate of decrease in serum glucose is about 75 to 100 milligrams per deciliter each hour. This occurs because there are a limited number of insulin binding sites. Once serum glucose declines to 250 milligrams per deciliter, glucose should be added to the IV fluids. As previously noted, DKA results in an anion gap acidosis. Factors contributing may include ketones from the ketoacidosis, lactate from hypoperfusion secondary to hypovolemia, or organic acids from renal insufficiency. Treatment of acidosis with sodium bicarbonate is controversial. On the one hand, increasing pH to greater than 7 clearly improves myocardial function. On the other hand, rapid correction of acidosis may cause central nervous system problems due to paradoxical worsening of CSF and central nervous system acidosis. This may occur as bicarbonate is converted to carbon dioxide and diffuses across the blood-brain barrier. Other contributing factors potentially involved in the paradoxical acidosis include decreased cerebral blood flow and development of osmotic gradients between the blood and brain. Now let's look at the perioperative management of hyperglycemia. Prior to 2000, it was common to not treat hyperglycemia unless the blood sugar was greater than 250. In 2001, the Vandenberg study reported a decrease in mortality in ICU patients if the serum glucose was maintained between 80 and 110 milligrams per deciliter, compared with a target of 180 to 200. Despite many people pointing out the limitations of this study, for example, it was not possible in routine clinical care to duplicate the intensity with which the patients were monitored during the study, several government agencies and the American Diabetes Association adopted the recommendations advanced by Vandenberg and used them as an indicator of quality. In the first few years after the Vandenberg study was published, a series of other studies were published which failed to document any difference in mortality, but did demonstrate that as many as 28% of patients managed according to the tight glycemic control guidelines developed significant hypoglycemia. In 2009, a study involving over 6,000 patients in over 40 centers was published. The study used an algorithm known as NICE Sugar, which stands for Normoglycemia in Intensive Care Evaluation, Survival Using Glucose Algorithm Regulation. That study documented that not only did adherence to the target of tight glycemic control result in increased incidence of hypoglycemia, odds ratio 14.7, p less than 0.001, but also documented an absolute increase in mortality in these patients, odds ratio 1.14, p equals 0.02. Subsequent meta-analyses have reported no overall effect on mortality for patients managed along the tight glycemic control guidelines, but an absolute increase in the frequency of hypoglycemia. Current recommendations from the American Association of Clinical Endocrinologists and the American Diabetes Association is that insulin infusion not be initiated unless blood sugar is greater than 180, and that once an insulin infusion is started, the target should be 140 to 180. This table is from an article in Anesthesiology published in 2017. You might want to pause the presentation here to review the table, but there are a few things that might simplify it. First, for everything other than the non-insulin injectables, the recommendations are not altered by whether or not the patient has had a bowel prep or clear liquids only for 12 to 24 hours pre-op. Second, if a dosage reduction is recommended, the recommendations are to give 80% of the usual dose. Finally, only for NPH insulin do the recommendations include a reduction in the morning dose. This is a one-part session on lung ultrasound. This session is actually a combination of keywords from two collections, respiratory and anatomy. It made more sense to me to combine them into a single presentation, so I've taken the liberty of doing that. I'll start with ultrasound anatomy of the normal lung. This includes not only normal findings, but also the appropriate techniques for lung ultrasound. Although lung ultrasound may be performed with a linear, curvilinear, or phased array probe, the linear probe is best when examining more shallow structures, for example, the pleura looking for sliding, and the curvilinear is best when looking for deeper structures, for example, when looking for B-lines. This ultrasound demonstrates a normal pleural line. It appears as a horizontal, hyperechoic structure below the ribs and represents the interface between the visceral and parietal pleura. The image produced by the ribs with their acoustic shadowing and the hyperechoic pleural line has been termed the bat sign. Purportedly, the pleural line is supposed to represent the body of the bat, and the two ribs represent its wings. No matter how hard I look, I don't see a bat in that, but if you do, more power to you. Your imagination is obviously better than mine. Disclaimer, I am not an artist. This illustration attempts to show the transducer, skin, gel, ribs, and pleura, all of which are labeled. A-lines are a classic example of reverberation artifact. In this sequence, the transmitted beam, blue, strikes the pleura, green, and is reflected to the transducer, red dotted line, which generates the image of the actual pleura as a hyperechoic line. The original ultrasound beam also bounces or reverberates between the skin and the pleura, as shown by the red arrow. Some portion of the reverberated beam is also reflected to the transducer, as shown by the pink arrow. Remember that the ultrasound machine determines the depth of an object, orange arrow, based on how long it takes the reflected signal to be returned to the probe. Because the reverberated signal takes approximately twice as long as the reflected signal from the original beam, as indicated by the longer orange arrow, a reverberation artifact, light green, appears at a depth approximately twice the distance between the skin and the actual pleura. This ultrasound demonstrates an A-line. As previously described, it is a reverberation artifact of the pleura, which appears as a horizontal line at a depth that is a multiple of the distance between the skin and the actual pleura. There are several characteristics of A-lines. First, they are identical in shape to the pleural line. Second, they occur at regular intervals deep to the pleural line. And finally, the brightness is diminished with each replication. Lung sliding represents the motion of the visceral pleura over the parietal pleura. By definition, lung sliding is a dynamic process. As shown in this video, it appears as shimmering or sliding between the two layers. Normal lung sliding may be represented by a still image obtained in M mode, the results of which are termed the seashore sign. Ostensibly, the parallel lines at the top of the image, indicated by the blue arrow, represent waves, and the granular texture below the pleural line, indicated by the red arrow, represent the sandy shore. These are the images that will be addressed in this section. While not exactly pathologic, a mirror image artifact merits at least a brief comment. Watch this video. Notice that although the pleural line moves, there is no shimmering or sliding evident. This indicates the absence of lung sliding. Notice the difference between the motion of the pleural line, which is absent from the video on the right. Lung sliding is present on the left, but absent on the right. This is an M-mode image that occurs in the absence of lung sliding. Termed the barcode or stratosphere sign, the area below the pleural line shows parallel lines essentially indistinguishable from the area above the pleural line. Here's a side-by-side comparison of the seashore sign and the barcode sign. Notice that the differences are confined to the area below the pleural line. Obviously, the first prerequisite to see lung sliding is that the lung underlying the probe must be receiving ventilation. An esophageal intubation, apnea, or intubation of the contralateral main stem bronchus will all result in the absence of lung sliding. Also, the interposition of anything between the visceral and parietal pleura will result in the absence of lung sliding. Examples obviously include air or blood. Finally, although perhaps not common in the general population, a pleurodesis or a prior thoracic surgical procedure which resulted in scarring between the two layers of the pleura will also result in the absence of lung sliding. This video demonstrates what's termed a lung point. Notice that no lung sliding is present to the left of the red arrow, and the lung sliding is sometimes present to the right of the red arrow. Here's another video that demonstrates a lung point. No lung sliding is evident to the right of the red arrow, and is sometimes present to the left of the arrow. A lung point identifies the point at which the visceral and parietal pleura become separated in an pneumothorax. When imaged in M mode, a lung point presents as a seashore sign, alternating with a barcode or stratosphere sign. As already noted, the absence of lung sliding can be caused by a variety of conditions. The presence of a lung point is essentially pathognomonic for a pneumothorax. Watch this video for 4 or 5 seconds and answer the question of whether lung sliding is present or absent. While there is clearly motion of the pleural line, it is synchronous with the heart rate, not the respiratory rate. This is termed a lung pulse. This M-mode image of a lung pulse clearly demonstrates that the image alternates between a seashore sign, blue arrow, and a barcode sign, red arrow. The presence of a lung pulse indicates that the underlying lung is not being ventilated. Another potentially pathologic finding on lung ultrasound are B-lines. B-lines are the result of widened intralobular lung septa and permit propagation of ultrasound waves. This image shows multiple B-lines. By definition, B-lines are hyperechoic, discrete, begin at the pleural line, move with lung sliding, extend to the periphery, and obliterate A-lines. Notice how these characteristics are present on the adjacent image. While not a great image, this video shows B-lines moving with lung sliding. Since a normal lung fissure may result in a B-line, to be considered pathologic, there must be 3 or more B-lines in a single interspace. The presence of B-lines under the probe is consistent with anything that causes widening of intralobular septae. Limitation of B-lines to one area of the lung, for example the right lower lobe, is consistent with a localized process, pneumonia. The presence of B lines throughout both lung fields suggests more generalized pathology, for example, pulmonary edema. Next, we'll talk about the spine sign. Here's an abdominal ultrasound showing the diaphragm, liver, and kidney, all of which are labeled. This image actually shows two pathologic features. Although not relevant to the discussion of lung ultrasound, the blue arrow indicates Morrison's pouch, the potential space between the liver and the kidney. The liver and kidney should be immediately contiguous. The fact that there is a hypoechoic area between these two structures is consistent with some form of free fluid in the abdomen. What's more interesting from the perspective of lung ultrasound is what's termed the spine sign. Normally, presence of air in the lungs results in the inability to visualize the spine above the diaphragm.